I'm Dr. Luke Evnen. I'm the chairman of the board at the Scleroderma Research Foundation, and I'm also a scleroderma patient. This is our 18th live webinar, and I'd like to remind everyone that our entire series, as well as a variety of other patient and research-related news, are available to you at no cost at our website, which is sclerodermaresearch.org. As I've said in the past, the Scleroderma Research Foundation, the SRF, depends on your support to accelerate progress toward better treatments and, ultimately, a cure. So, please consider making a donation after our time together today. Our webinar series is made possible through a generous grant from Gilead Sciences. They've been a terrific partner, and we thank them for their support. Today's session will feature roughly 40 minutes on recent developments and treatments for scleroderma-related pulmonary hypertension. We'll then wrap up with about 15 minutes of question and answers. The phone lines have all been muted for now, so if you do have a question, please use the chat box in the conference window. Also, please remember our webinars are for educational purposes only, and no information provided is to be considered personalized medical advice. It's now my great pleasure to introduce our special guest. Dr. Yon K is the clinical instructor of pulmonary and critical care medicine at Stanford. She received her Bachelor of Science in Chemical Engineering, as well as a certificate in engineering biology from Princeton University. She received her MD from the University of Pittsburgh School of Medicine and did a postdoctoral fellowship at Stanford's Division of Pulmonary Critical Care. Dr. Sung's clinical focus is on pulmonary diseases. She is the author or co-author of 11 scholarly articles on pulmonary hypertension and organ transplantation. And needless to say, she's an expert on today's topic, an update on scleroderma-related pulmonary hypertension. It's now my great pleasure to introduce Dr. Sung.
Good morning. Thank you.
Thank you.
Thank you, everyone, for coming. It's a real honor for me to present this topic to all of you, and I hope it will be very informative. Okay, hold on. Okay. So, I'm sorry. So what we'll discuss today is I'll introduce why pulmonary hypertension and systemic sclerosis is an important problem. We'll talk about different causes of pulmonary hypertension and systemic sclerosis. We'll review the diagnostic testing that's involved in making the diagnosis. I'll talk about epidemiologies and risk factors for PH in scleroderma, screening mechanisms, as well as treatment, and some future therapies which we're all anticipating. So first of all, pulmonary arterial hypertension is an important cause of mortality in scleroderma. As you can see from this graph, historically speaking, the rise of PAH as a cause of mortality has been increasing since the 70s. So back in the 70s, scleroderma renal crisis in the white bar was the leading cause of mortality. But as the treatment for this has improved, the mortality associated with scleroderma has become mostly lung diseases. So this point, from 97 to 2001, the leading cause of death in patients with scleroderma was pulmonary fibrosis, and a close second was pulmonary arterial hypertension. And with more current data, this continues to be true. So this study was done in 2010, looking at a registry of systemic sclerosis patients in Europe. And again, out of scleroderma-related death causes, which was 55% of the entire group, pulmonary causes were the leading or most frequent cause, in total 33%, and overall PAH was a cause of death in 14% of cases. So unfortunately, scleroderma and pulmonary hypertension has very high morbidity that goes with it. So if we look at all patients with pulmonary arterial hypertension, so as we'll talk about soon, there are many other causes of pulmonary arterial hypertension, not just scleroderma. So this is the survival curve, so time for years, and then survival here on the y-axis. And what we can see is the red line is idiopathic pulmonary arterial hypertension, which is people who have PAH for no other known cause. And if we look at the connective tissue disease-associated PAH, which scleroderma falls under, this is the blue line, we see that survival is really much worse, and that 5-year survival rides around 50%. And then among the connective tissue disease PAH patients, unfortunately, scleroderma has the worst survival. So if you compare the patients with rheumatoid arthritis and PAH, their survival is actually quite good. And lupus as well, their survival is also quite good. But as you can see in this blue line, the scleroderma patients tend to have worse survival. So 1-year survival of 82% and 2-year survival of only 70%. So what exactly is pulmonary hypertension? So before we start explaining this, I'd like to go over just what the normal heart-lung circulation is. So the heart, as I'm sure you all know, is responsible for pumping blood to your body. So blood goes from the left side of your heart out through the aorta, and it supplies blood to your head and your lungs, or your head and your legs, and it delivers oxygen and nutrients. When it's all finished, it circles back around. It's deoxygenated blood, which is why this is blue here. It comes back to the right side of the heart, goes in through the right atrium, down to the right ventricle, and then out to the lungs. And in the lungs is where it picks up oxygen, and then it goes back through the pulmonary veins and then continues around in a circle like that. Okay. So pulmonary just means lung, and hypertension just means high blood pressure. So pulmonary hypertension is high blood pressure in the blood vessels of the lung specifically. So this is a different condition than people who have just regular high blood pressure, such as when you go to the office and get your the blood pressure measured on your arm with a blood pressure cuff. So if this is the normal appearance of the heart and lung, what can happen is when the blood pressure of the blood vessels of the lung increases, this really affects the right side of the heart, which needs to then work harder to pump more blood into the lungs. So then what we can see there is that when you have diseases of the pulmonary vasculature, you can notice you'll find that the pulmonary arteries will be more narrowed. And then as the right ventricle has to work harder, you'll find that this right side of the heart can be more dilated, so bigger here. And then the right side, the muscular wall can become more thick. So then what kinds of symptoms does this all cause? Basically, the right side of the heart is not able to keep up with activities, with your level of activity. So the most common symptom is shortness of breath and decreased exercise tolerance. Lots of patients also experience general fatigue. Chest pain and palpitations are also present, although slightly less common. And then when people have more severe disease, they can have lightheadedness, fluid retention and swelling in their legs or in their abdomen, and in very serious cases, people can even have episodes of passing out. So what are the different causes of pulmonary hypertension and systemic sclerosis? So this is, as we'll find, is not just one disease entity. So oops, excuse me. So one of the main causes and the disease that we'll focus on throughout most of this talk is a disease that's called pulmonary arterial hypertension. And that is a disease in which the small pulmonary arteries, so the small arteries in the lung, get diseased such that there is a lot of remodeling of the vessel and complete occlusion. And so that's what you can see in this picture here. And it's important to make a distinction between this type of pulmonary hypertension from the other types of pulmonary hypertension I'm about to discuss, because that has implications for appropriate treatment. Okay. Other causes include a rare condition called pulmonary veno-occlusive disease, where the disease part of the lung vessels is actually the vein as opposed to the artery. Other common things can include problems with the left side of the heart. So as you can imagine, if for whatever reason this side of the heart is not pumping well, so instead of blood going forward like this, it can back up into the lungs and cause increased pressure like that, or like this. And so in scleroderma, there are many reasons people can have left heart disease. So as I'm sure some of you may know, scleroderma itself can attack the heart muscle and cause dysfunction that way. Additionally, certainly as people get older, they can have very common things that cause left ventricular disease, including just regular coronary artery disease and other heart failure problems. Another cause of pulmonary hypertension is if you have a disease of the lung itself. So certainly in scleroderma, I'm sure many of you know that interstitial lung disease itself is a common problem in scleroderma, and this can also cause some mild degrees of pulmonary hypertension. Lastly, people can get what are called chronic blood clots in the lung, and this is known as an entity called CTEPH, or chronic thromboembolic pulmonary hypertension. So basically, if you get a blood clot here in these blood vessels, that will then obstruct the blood flow from the right side and increase the pressures. So this is organized into this classification of different types of pulmonary hypertension. And so as you can see, there are many, many different causes, and the areas that I've boxed show the different causes of pulmonary hypertension that we can see in patients with systemic sclerosis. Okay. So to focus specifically on pulmonary arterial hypertension, what we see in the disease process is that the normal pulmonary artery vasculature is a very thin-walled tube where the blood flows. So generally just one layer on the inside, one layer of muscle on the outside. Okay. As the disease progresses, we can start to see thickening of the muscular cells around the blood vessels, so this becomes thicker. And as time goes on, these cells can go a little bit crazy and continue to proliferate. These walls can get thicker. The cells lining the inside of the vessel can also proliferate and cause complete occlusion. And as the disease progresses, you can start to see what are called plexiform lesions, and that's what this thing looks like. It's basically a very complex lesion which is completely occluding the vessel. Okay. So how do we diagnose this disease? So for most patients, the initial suggestion that people have pulmonary hypertension is based on a study called an echocardiogram, which is basically an ultrasound image of the heart. And with this study, what we can do is estimate the pressure in the lung with something called the right ventricular systolic pressure or the pulmonary artery systolic pressure. And we suspect pulmonary hypertension when that pressure is greater than 40. For normal patients, often the pressure cannot be measured, or it tends to be very low, or 25 to 30-ish or so. In addition, other findings on the echocardiogram that can suggest pulmonary hypertension include enlargement of the right ventricle as well as dysfunction. And sometimes you can also see the pulmonary artery, which may be dilated. Okay. So these are some examples of echocardiogram pictures. So this is a heart. This here is the right side, and this is the left side. So in a normal heart, you can see that the right side of the heart is much smaller than the left side of the heart. But in pulmonary hypertension, you can see that this right side of the heart becomes very enlarged. And if we were to actually see this motion, you could see that it's also not squeezing very well. Okay. If we look at another view with this echocardiogram, this is called the parasternal short axis. This is a cross-section of the heart, and so this is the left ventricle on end, and you can see the right ventricle here, sort of right by its side, and you can see this is a normal size. With pulmonary hypertension, you can see that this right side of the heart becomes very enlarged, and often we can see that this becomes so enlarged and the pressure is high enough that it squishes this left side of the heart, so we can often see flattening of the septum here. Okay. So once patients present with symptoms and we have an echocardiogram that's suggestive of pulmonary hypertension, what do we need to do to fully diagnose the condition? So this involves really a very large battery of testing, and the important thing for us as clinicians is really to fully characterize what kind of pulmonary hypertension you have, because as I mentioned, that has different implications for the treatments that we would offer patients. So in addition to realizing that scleroderma is a risk factor, we recommend that all patients be checked for HIV and hepatitis. These conditions can also cause pulmonary hypertension, so that's something we don't want to miss. Certainly, I mentioned that left heart disease, which is group 2 pulmonary hypertension, can cause some degree of PH, so the echocardiogram will also give us information on that. And in some cases, especially for patients with scleroderma patients who can have disease of the heart muscle itself, a cardiac MRI can sometimes be very helpful. We also want to make sure that there isn't any underlying lung disease or interstitial lung disease that's a cause of the pulmonary hypertension. So this involves getting full pulmonary function tests, arterial blood gas, CAT scan of the chest, as well as checking for obstructive sleep apnea, which is also a very common cause of pulmonary hypertension. And then lastly, to look for chronic blood clots, the test of choice is called a VQ scan. Okay? And depending on if this is positive, you may consider other supplemental tests to go with that. Additionally, all patients with pulmonary hypertension should have some kind of functional study. The most common thing we use is called a 6-minute walk test, which is just walking back and forth for 6 minutes. That helps us assess how limited you are in terms of your cardiopulmonary disease. Okay. And then the definitive test to tell you whether you do or don't have pulmonary hypertension is a procedure called the right heart catheterization. So I think at most institutions, and certainly at our institution, we do this procedure in the cath lab, so under full sterile conditions. The patient is under here, under all this drape. And what we do is basically fish a catheter that looks like this. It's a long, skinny tube, either often through the SVC, or this superior vena cava, or sometimes we go through this vessel, the IVC. So this would be either through your neck here or through your leg here. And then we would fish the catheter basically into the heart and then into the lungs. And that way we can directly measure the pressures. Okay. And so exactly what do we need when we're in there? So we need pressure. We need to assess the right atrial pressure, the right ventricular pressure, the pulmonary artery pressure, and then something called the wedge pressure, which basically tells us whether a lot of the pressure is coming from the left side of the heart. With this procedure, we can also measure cardiac output, which is a measure of how well the heart is squeezing. And then from all these things, we can calculate the pulmonary vascular resistance, and that basically tells us how closed off the pulmonary vessels are. We also assess the oxygenation in each of these vessels. That also helps us calculate the cardiac output and tells us also possibly if there's some kind of congenital defect. Sometimes we'll do angiography, which is basically shooting dye into the pulmonary vessels to see what the vessels look like. And then often we'll do something called vasoreactivity testing. So patients are given either some kind of vasodilator. So we often use inhaled nitric oxide, which is an inhaled gas, but there are other medications that can be infused through the IV. And then we see how your pressures respond to that medication. So for most patients with scleroderma pulmonary hypertension, you will not see a significant change. So for people who do have a positive what's called vasoreactive testing, they fall into a special category where the therapy is different and the prognosis is different. So, okay. So then with the right heart catheterization, that's when we know exactly whether we have pulmonary hypertension. And pulmonary hypertension is basically defined as if you have a mean pulmonary artery pressure of greater than 25. So as I'm sure most of you know, when you measure pressure, there's like a systolic pressure and a diastolic pressure, or a top number and a bottom number. And we can use that to calculate what's called a mean or an average. And so a normal mean pulmonary artery pressure is 10 to 20, and so 25 is when you have pulmonary hypertension. The definition of pulmonary arterial hypertension, so the group 1 pulmonary hypertension, is a mean pulmonary artery pressure of greater than 25, as well as a wedge pressure that's less than 15, and that again tells us that there's no problem with the left side of the heart. And then a pulmonary vascular resistance of this measure called of greater than 3 Woods units, which is an arbitrary measure. Normal would be less than 3. Okay. So then you may be asking yourself, well, what are my chances of getting pulmonary arterial hypertension? So in general, this is still a very rare disease. In all cases of pulmonary arterial hypertension are about 15 cases per 1 million. But it is certainly more common in people who have any kind of connective tissue disease. So the estimates are that it's about 15 to 30% of patients, or of all of the PAH patients, have some kind of connective tissue disease. For all patients with systemic sclerosis, it's estimated about 8 to 13% of patients will develop pulmonary arterial hypertension. So certainly the larger group of all pulmonary hypertension may be a higher number than this. And then what we see of all the connective tissue disease patients is that certainly scleroderma is a much higher risk factor than other connective tissue diseases. So the bulk of patients, connective tissue disease PAH patients, have scleroderma. So this is a group of patients studied in the UK, and this is a group of patients studied in the US. So as you can see, the bulk of patients have systemic sclerosis. So many studies have looked at trying to understand what the risk factors are in scleroderma for developing PAH. So it's more common in scleroderma patients who've had disease for a very long time, more common in people who were older when they were diagnosed with scleroderma. It becomes more common in the postmenopausal period. More common in people who have very severe Raynaud's phenomenon and evidence of digital ischemia or digital ulcers. Also, cutaneous telangiectasias have been shown to be a risk factor. And then these are 2 pulmonary function test measures. So the DLCO stands for diffusing capacity. And that's basically an assessment of how well your lung is able to take up oxygen. So for some patients who their other testing is normal, but their diffusing capacity is low, that is a risk factor for pulmonary hypertension. And then if you compare the sort of lung volume measurements, which is the FVC, compared to the DLCO, if the DLCO is, again, disproportionately low, so a ratio of greater than 1.6, that is also a risk factor. And lastly, if you have serial echocardiograph measurements and the right ventricular systolic pressure is increasing by more than 2 millimeters of mercury per year, that is also suggestive of portends a risk for pulmonary hypertension. On this side, what we see is also many of the autoantibodies that are checked for pulmonary hypertension suggest that there's an increased risk. So for the most part, anti-centromere antibody, anti-U1 RNP antibody, as well as all of these other antibodies. Interestingly, if you have an SCL70 positive antibody, that actually is thought to be somewhat protective from the development of PAH. So given this is a pretty deadly disease, there are actually recommendations for screening for pulmonary hypertension in all patients with systemic sclerosis. So what would be the benefit of this? So what we see is that for patients who've been sort of monitored for pH, so this is a study from the Pharos registry, which is basically a registry of people who, scleroderma patients who don't have pulmonary hypertension, but they're thought to be high risk. And they're included in this group if they have an elevated RVSP on their echo of greater than 40, a diffusing capacity that's less than 55% predicted, or an increased FVC to DLCO ratio of greater than 1.6. So in this cohort of patients, we find that the survival, the 1-year survival is 92%, 2 years is 87%, and 3 years about 74%. So certainly compared to that earlier data I showed you from the REVEAL registry, which showed that 3-year survival for scleroderma PH was about 55%. So the thought is that these people who are being monitored, who are high risk and being monitored, are having better survival. So the thought is earlier diagnosis will lead to earlier treatment and hopefully better survival. So there have been many studies that have looked at different tests to assess for the risk of developing pulmonary hypertension. So, and the most definitive of these was called the DETECT study, which was published in 2013. So this study took 466 patients with scleroderma and just screened all of them for, with a number of different tests. And patients were included if they had had disease for at least 3 years and a diffusing capacity on their lung function test of greater than 60%. And then all of these patients eventually went on to right heart catheterization to determine whether they did or didn't have pulmonary hypertension. And what they found was that for the most part, let me back up. So after they determined who had pulmonary hypertension and who didn't, they looked at all of the screening tests before and then determined which non-invasive testing was predictive for predictive for pulmonary hypertension. And with this algorithm, they only missed about 4% of cases. So this is what the algorithm looks like. Basically, out of everything, all the features they looked at, the things that were predictive were having was the FVC to DLCO ratio, the presence of telangiectasias, the presence of an anti-centromere antibody, an elevated serum NT-proBNP, and that is a blood test measure that tells you how much strain there is on the heart, a serum uric acid, and then as well as an EKG that suggests that there is some problem with the right side of the heart. So with this, you can, depending on the level of each of these measures, you can use this nomogram to calculate a score. If the score is elevated, patients were referred for echocardiogram, and if they had certain findings that were suggestive of PH, specifically the right atrial area, as well as the tricuspid regurgitation velocity, that's basically how you measure the RVSP. Again, if that score was elevated, then patients went on to a right heart catheterization. So the nomogram for scoring all these things kind of looks like this. So for example, if you have telangiectasias, you get a score of about 65 on this. Whereas if you don't, you go to score of 50. And then for each of these things, you can add up all the numbers and then get a total score. As you can imagine, this is a little bit cumbersome. And so in practicality, I think certainly myself and my colleagues are not specifically using this algorithm, but I think what we're doing is taking these pieces and using that to help assess your risk for pulmonary hypertension. Okay. All right. So if you look at the most recent pulmonary hypertension guidelines, the recommendation is that annual screening for PAH is recommended for all patients with systemic sclerosis. And that screening should include some assessment of the presence of telangiectasias, anti-centromere antibody, lung function test with a DLCO measurement, echocardiogram, NT-proBNP, and then followed by echocardiogram and right heart catheterization if appropriate. Okay. So once you've determined that one has pulmonary arterial hypertension, right? So again, that's just that group 1 phenotype. We can move on to trying to treat it. So for the most part, so this is the algorithm for treatment. This is all types of pulmonary hypertension. So general measures or supportive things we can do are to do some supervised exercise training, avoiding very strenuous physical activity, avoiding pregnancy because that is a very high-risk condition associated with pulmonary hypertension, of course, getting your routine vaccines. It's recommended that patients go to an expert referral center for full evaluation, including the right heart catheterization. During that right heart catheterization, patients should have a vasoreactivity test, and if they are positive, then they can be treated with these CCBs, which are calcium channel blockers. As I mentioned, most patients with scleroderma PH will be non-vasoreactive, and then we'll move on. So then they should be started on the PAH-specific therapies. Okay. So what are these? These medications basically target 3 main pathways. The endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. So basically all of these pathways are involved in either vasoconstriction, so narrowing of the vessels, or vasodilation, opening of the vessels. Okay. So first we'll start with the nitric oxide pathway. So the first class of medicines is called PDE5 inhibitors, or phosphodiesterase 5 inhibitors. Basically, so nitric oxide leads to the production of cyclic GMP, and that causes vasodilation. This molecule, PDE5, destroys the cyclic GMP. So if you're able to inhibit this, that allows more cyclic GMP to be around and allows for more vasodilation. So in the U.S., we have 2 medications that attack this pathway called sildenafil and tadalafil, and these are oral pill medications. There is a second medication that also targets this pathway called riociguat. So as I mentioned, nitric oxide becomes cyclic GMP. It becomes cyclic GMP with the help of this enzyme called soluble guanylate cyclase. So riociguat basically stimulates this enzyme to produce more cyclic GMP, again leading to vasodilation. This is a relatively new medication, was FDA approved just 2 years ago. The next pathway is called the endothelin pathway. So what happens here is that this molecule, endothelin, binds to these receptors which cause vasoconstriction. So our medications are endothelin receptor antagonists. They block this receptor and prevent the vasoconstriction. So we have 3 current therapies available for this. These are all oral medications, so bosentan, ambrisentan, and macitentan. The last class of medicines are called prostacyclin pathways. So prostacyclin leads to the production of this molecule called cyclic AMP, and that causes vasodilation. So we have lots of options, but they're in this category, but these are certainly more complicated than just oral pill therapy. So epoprostenol, which was the first FDA-approved therapy for PAH, is an IV continuous infusion medication. So it's basically people have an indwelling IV line, and they're connected to a pump that runs medication 24 hours a day, 7 days a week. There's a second option called treprostinil. It comes in an IV form as well as a subcutaneous form. There's an inhaler form and an oral form. And lastly, there's iloprost, which in the U.S. is only available as an inhaled form. So out of all of these therapies, how do we decide which therapy to start? And this pretty much is based on people's symptoms. So this WHO FC2, which stands for WHO Functional Class. 2 is basically people who maybe have very mild symptoms but not too many symptoms. WHO Functional 3 is people who have a lot of symptoms, so everyday activities are pretty difficult. And then WHO Functional 4 are people who have symptoms even at rest, or people who are having episodes of passing out. So what we can see here is that for people who have pretty mild symptoms, they recommend starting some kind of oral therapy. Whereas people who have very serious symptoms, the recommendation is actually to start with continuous IV therapy. And then for everybody else in between, you can pretty much pick whatever you want, and this is where it often is tailored to specific patients and their needs. So the current recommendations have been to start with one of these medications, and then if you don't have a good clinical response, meaning that you continue to have symptoms, additional therapies are added to the point where people are often on one therapy from each class. If they continue to have a poor response, then the consideration is to be referred for a lung transplant. Okay. So while that is the current guideline, there was a recently published trial called the Ambition trial, which looked at treating patients up front with more than one therapy. So basically, instead of just starting one, waiting for that to see if that therapy will be helpful, and then starting the next one, these patients were started on 2 medicines at once. So it was a double-blinded, randomized, placebo-controlled trial. Patients were started either initially with tadalafil and ambrisentan at the same time versus tadalafil alone or ambrisentan alone. There were 500 patients in this trial. And what they measured was the time to first clinical event, meaning either death, hospitalization for worsening pulmonary hypertension, disease progression, or an unsatisfactory long-term clinical response, meaning that they didn't have improvement in their symptoms. And what they found was that people who were initially started on combination therapy had a much longer time before they developed an event versus the people who were started on one therapy. Certainly this is suggestive that it's something we should consider. However, this study does have some limitations. What they did notice at 24 weeks, so 6 months, was that there was no difference in the different groups in WHO functional class, meaning sort of their overall activity abilities. They also note that it's unclear if this data can be extrapolated to other drugs in the same class. So, for example, tadalafil or sildenafil instead of tadalafil, or macitentan instead of ambrisentan, or if it can be extended to combination therapy with the prostacyclins. Okay. And it's also unclear from this data if people who had been on monotherapy would have improved if they had started on the other medicine instead of the one that they were assigned to. All right. Okay. And this approach has actually also been studied in scleroderma PAH patients specifically. There was a trial of 24 systemic sclerosis patients. This is open label, so there was no placebo comparison group. But they were started up front with tadalafil and ambrisentan. And this study showed that at 36 weeks, patients had improvement in their hemodynamics, so improvements in their pulmonary vascular resistance, as well as other measures of right ventricular function, as well as improvement in their 6-minute walk distance, and NT-proBNP. Okay. All right. Okay. So lastly, I just want to close with a few. Excuse me just for a second. Some things that are coming down the pike, which I think are pretty exciting. So what I mentioned, all these therapies that we currently have are basically pulmonary vasodilators. And as you can see from the pathology slides that I showed you, often you get remodeling of the vessel so that they're completely occluded. So it's very hard to imagine that something that just dilates a vessel is going to open something that is basically completely occluded with a lot of cells. So there is a lot of interest in trying to find therapies that will actually reverse that remodeling. Okay? And I'm just going to talk about 2 strategies. So the first is rituximab. So rituximab is an anti-inflammatory medication. It basically depletes all the B cells, which are cells that produce antibodies. This is actually currently an NIH run trial there are 13 clinical sites, and they're comparing 2 doses of rituximab versus placebo. So this trial is currently running, and we hope to have results in the next year or so. The second therapy, or the second target that I want to discuss is something called leukotriene B4. So that is an inflammatory, it's a lipid mediator, and it's an inflammatory marker. And what we've seen in this study is that patients who have systemic sclerosis, pulmonary hypertension, have very high levels of LTB4. So this is a normal where you don't see very much, versus patients with systemic sclerosis where you can see a lot of this red staining in these vessels. Also, when you measure LTB4 in patient serum for people who have connective tissue disease pH, and I'll tell you that most of the patients in this group had scleroderma, they have very high levels compared to even idiopathic pH or control patients. Okay? And so in this study, they also, they then tried to see if we could reverse pH in animal models. So when they treated animal models who had very severe pH, so this is this group with very high right ventricular pressures and a lot of remodeling of their right ventricle. And then they treated them with molecules that inhibit LTB4, so, which are these 3. We found that they had significant reversal of their pressures as well as the thickness of the right ventricle. Okay? And so one of these molecules, BE here, which is bistatin, is actually something that we're going to be testing in clinical trials soon. So bistatin, which is a molecule that inhibits LTB4, is actually an approved chemotherapeutic agent in Japan. And so this is very recent news. This company has actually licensed the agreement to develop bistatin here in the U.S. for treatments of diseases where inflammatory diseases that have a high LTB4, and very specifically pulmonary arterial hypertension. And I think we hope to be starting clinical trials for this early next year. Okay. So in summary, I hope that I've relayed that systemic sclerosis is a very strong risk factor for the development of pulmonary arterial hypertension. Patients who are suspected to have PH should undergo a full workup to confirm the diagnosis and to determine the cause of PH. For patients with systemic sclerosis, screening tests are very useful for detecting early disease. Current treatments are with pulmonary vasodilators, but in the future we hope that we may target inflammation, the immune system, and the remodeling. So thank you very much for your attention. I will be happy to answer questions at this point.
That is really a great summary. Thank you very much, Yon. I'm just going to go ahead and take the lead and ask a couple of questions. Obviously, some of the data up front about survival is a little bit intimidating, and then we showed a little bit of data farther down the presentation about things that patients might consider that could affect some of these Kaplan-Meier population survival curves. I wonder if we just want to talk a little bit about some of the data that was generated. I think originally with mastacentin on top of pre-existing therapy, which did demonstrate a survival advantage. Admittedly, that was in a broad age population, but I think just to give some of the listeners a little bit of perspective on some of the directions that are being taken in the evolution of therapeutic options.
Sure. So I think, well, let me see if I'm answering your question correctly. So for those who don't know, the mastacentin is sort of one of the more recently approved medications. It's on that endothelin pathway that I had described. And the clinical trial for that medication actually was a very long trial where they showed that that medication on top of other pulmonary hypertension medications sort of delayed the time to clinical worsening. And what I think, if you look at all of the early trials for pulmonary hypertension, many of them were very short trials, 12 weeks, 16 weeks, that only looked at change in 6-minute walk distance. And I think the field really is now progressing to doing longer trials and really determining hard clinical outcomes. So things like hospitalization and death and worsening functional class and things like that. So I think certainly the trend in PAH is to really show that medications are not just affecting sort of what we call soft outcomes, but more harder outcomes that are, I think, clinically relevant to patients. I'm not sure if that's answering your question or not.
No, that's helpful. Thank you. I thought maybe we talk just a bit about why you think the disease might be worse in scleroderma patients, just because sort of an intriguing challenge, if you will, for some of the research challenges that we have in understanding why scleroderma patients who have seemingly the same disease do worse. I wondered if you want to help some of our listeners understand what some of the other issues that are involved, or just to understand kind of the complexity of the challenges that we have on the research side.
Sure. So I think, certainly, and I didn't present this data, but they have looked at, they have compared patients with idiopathic pulmonary hypertension versus scleroderma, PAH, and unfortunately, even if you look at the hemodynamics, so if you look at the pulmonary artery pressure or the cardiac output, even if their patients with scleroderma tend to have quote unquote milder disease, meaning that the pressure is not quite as high. But what they find is that even with sort of lower pressures or a better hemodynamic profile, patients with systemic sclerosis tend to have a poorer survival. And so there are lots of reasons to speculate why that might be. I think some of the thought is that, as I mentioned, scleroderma can affect the heart itself. So there are some thought that perhaps in addition to the disease that you have in the lung, perhaps there's a disease also in the right ventricle or in the heart that's caused basically not allowing the right side of the heart to really compensate and generate better pressures. And so therefore decompensate more easily. There's also some thought that with that there's a lot of inflammation that causes just progression of the pulmonary vascular disease as well.
Let's see. Maybe just if we could talk just a bit about some of the other things that are going on the therapeutic side, switching gears. You did mention sort of oral vasodilators as things that are emerging, but maybe it would be, you talked about some of the other clinical trials, but my understanding is that sort of the next medication that's likely going to be approved or has a good shot at being approved would be an oral vasodilator. I wonder if you want to just help our listeners understand what the implications for that would be.
Right. So I think what you're talking about specifically is selexipag, right?
Yep.
Yeah. So selexipag is so as I mentioned, out of the three classes of medicines, right, first of all, they're all, for the most part, just vasodilators. The prostacyclins are probably the most potent vasodilators. But as I mentioned, most of them are either inhaled or continuous IV forms. There is one oral form, which I'll say is effective, but also not that well tolerated. There are a lot of side effects. There's a new medication, let me back up here. The prostacyclins, so in that pathway, they're basically all prostacyclin analogs. So they're molecules that are pretty similar to prostacyclin. So there's a new medication called selexipag, which is actually a prostacyclin receptor agonist. So it's not exactly a prostacyclin, but it binds to the prostacyclin receptor. So it works in the same pathway, but it's through a different mechanism. That's currently in clinical trial. in clinical trial or completing and should be reported soon and hopefully FDA approved soon. And that clinical trial was also very large and showed improvement in time to clinical worsening. And the hope is that, what we see with a lot of pulmonary, or with a lot of prostacyclins, is that they tend to have a lot of side effects. So the hope was that since this is not a prostacyclin, it's a receptor analog, that maybe there will be fewer side effects. And it is an oral medication, so that would be certainly easier in terms of use. I think, I don't personally have experience with it. We were not involved in the clinical trial. But my initial, from what I remember from reading the initial reports, is it's unclear to me whether the side effect profile is much better than the prostacyclins. But I think certainly as an oral alternative, it certainly will be a great option. It's also, the other thing I'll say is that it's unclear to me whether this will be more effective or as effective than our current prostacyclin. So.
Right. Obviously, the fact that it's a conversion from intravenous or sub-Q therapy to oral certainly offers some convenience options, even if the efficacy might be different. But I'm just going to go ahead and we'll just quickly summarize for us. And thank you very much, Dr. Sung, for a great presentation today and a fantastic summary of some of the challenges and some of the future opportunities in scleroderma-associated pulmonary arterial hypertension. Maybe just to try and bring it together a little bit for our audience. Obviously, everyone needs to go get your pulmonary function tests and make sure that if you are coming up with some symptoms that might suggest pulmonary hypertension, that you go ahead and pursue further diagnosis, because it does appear that early intervention could have some dramatic benefits, and so all of our patients should be thinking about that as an important.
And I will also say, on that screening algorithm that I showed, it does sort of recommend kind of a stepwise fashion. Certainly in this country, getting an echocardiogram is actually quite easy. So most of the practitioners I know don't necessarily start with a screening pulmonary function test or NT-proBNP and this other stuff and then decide to move on to echo. I would say most of us, for scleroderma patients, just recommend a yearly echocardiogram, and then we use that data in addition to the lung function test and NT-proBNP to decide whether we should proceed with heart catheterization.
Exactly. Thank you so much. I'm going to go ahead and close. I just want to remind everybody that we're all part of the same scleroderma community, and it's only by joining together that we can make faster progress in the search for better treatments and a cure. So with that in mind, when you close the webinar window, will you please provide some feedback information for us by completing a very short survey? It's much appreciated and very helpful for us. Also, please do remember that we depend on your support to enable our further investment in the most promising research. Visit us online at sclerodermaresearch.org, or feel free to call our offices at 1-800-441-CURE. That's 1-800-441-CURE. Coming up in January, we'll feature Dr. Janet Poole, an occupational therapist specializing in scleroderma and based at the University of New Mexico. I hope that you'll be able to join us then, and goodbye for today.